Well, thank you very much, and thank you for your kind invite to come to this meeting, and it's a pleasure. It's my first time attending this fantastic meeting, which is so inspiring. It's often said that physicians work by standing on the shoulders of others, and I think we as adult neurologists recognise fully it's the paediatricians who've led the way in Pompe disease, but I'm going to focus now on the late onset Pompe disease and particularly the adult patients. And it's of note, as you'll be aware, that 2 new treatments have been available now since the last AMDA meeting in 2019, and I'm going to talk about these treatments and the continuing unmet needs in all patient groups, including in adults. Just a few relevant disclosures. And I think already we've understood that Pompe is a complex disorder, and it is very much a spectrum disorder. That is, with infantile onset Pompe patients, as brilliantly described by Arnold Rosa earlier, essentially very little, almost no enzyme level, and a very severe phenotype with the involvement of the skeletal, respiratory, and prominently cardiac muscle, and of course later, as we've just heard, involvement of the brain. But I'm going to focus more on the late onset Pompe disease, a rather curious term meaning those over the age of 1. And of course that therefore includes children and juvenile and adult onset patients. All patients with Pompe by definition have it genetically from birth, but many will present surprisingly late and occasionally even in the elderly. These patients that I'll focus on have prominent skeletal and respiratory muscle involvement and rather less of cardiac involvement, although cardiac arrhythmia is still a concern in the adult patients. Crucially, unlike the infantile onset patients, the late onset and particularly the adult patients have a remarkably variable presentation. So there's profound heterogeneity with the degree of muscle weakness, how it affects the limbs, whether it affects more the spinal muscles, the paraspinal problems, the degree of respiratory problems, with some patients presenting with limb weakness and only later, for example, needing ventilatory support, and vice versa. Gastrointestinal problems are a common catch and indeed can be one of the first presentations of the condition, and sometimes brain involvement, more relevant actually perhaps in children and more confusing actually in adult patients where it's difficult to distinguish from other pathologies, particularly vascular disease, which is so common in the Western populations in particular. But there are 3 main particular types, and a beautiful picture here from one of Benedict Schoes's papers showing that it's very much a limb girdle syndrome, that is, with prominent proximal weakness around the shoulders and including the shoulder blades sticking out and around the hips. And it's a notable difference, in fact, to how pediatric patients can often have involvement of lower distal muscles causing foot drop and other problems. You don't tend to see this very prominently in the adult patients. You can see cardiac involvement and particularly heart rhythm problems. This is important to spot because of course heart rhythm problems can put you at risk of stroke. And as we've already mentioned, prominent involvement of the spinal muscles can cause people to present with twisted spines or scoliosis, so orthopedic consultants may see many of these patients first before they refer them on through to neurology. But although it's very heterogeneous, it's important to note that not just in the infants, of course, where it can be incredibly deleterious, in the children, the juveniles and the adults too, it is a progressive disease over the years and certainly leads to significant disability, wheelchair requirement and ventilatory needs in many patients. Talking again about how adult neurology and adult metabolics has learned from pediatric practice, of course with those very exciting early studies in infants, there was a very marked need with 5 times as many adult onset patients as infantile patients to see if this could actually generalize into a childhood and adult population. And the first big treatment trial, of course, was this LOT study, late onset treatment study, which was a randomized study as insisted by the FDA and indeed encouraged by the FDA to see if these benefits would occur in children and adults and not just in infants with a more rapid progression. And you can see in this important paper published by and led by Ansgar Plog's group that there was a clear difference with respect to the primary outcome measures, which were chosen to be the breathing capacity and the walking time, favouring the new product, ALG, subsequently called Myozyme and Lumazyme, ALG on these pictures, compared to the natural history, the placebo group, who unfortunately their breathing capacity and measurements such as MIP and MEP, which look at how the diaphragm works, all deteriorated over the randomized period of the trial. An obvious question is whether these early benefits are actually maintained, and initial studies actually looked very encouraging. So if you look at the breathing capacity there on the left-hand picture, and then the dashed lines is an open labeled extension study, that benefit in terms of breathing capacity is maintained. And so was the clear improvement in the 6-minute walking time. So there's no doubt at all that the first generation enzyme, Myozyme, Lumazyme, has changed the natural history in late onset Pompe disease, and not just infantile Pompe disease, but as you'll all recognise, there are still significant clinical needs. Focusing briefly on the infantile, of course not all infantile patients will actually show an improvement and can deteriorate early on. And in the real world, and there's some excellent pictures here from Pascal Lafare's excellent French registry data, you can see that in the late onset Pompe disease, with regard to the preservation of breathing capacity and the ability to walk quickly, the 6-minute walking test, after early improvements and stabilisation, there is undoubtedly a later deterioration after between 2 and 5 years. This has now been looked at by a large number of groups, including in the UK, but an excellent paper here from the STIG group that is a fantastic example of European cooperation between the Spanish, Taiwanese, Italian and German groups, clearly show, following up patients for up to 10 or more years, that after early improvements there's a clear deterioration in motor function, in walking time and in breathing capacity. It's of note, as in the children, that in many LOPD patients there may actually be initial deterioration without ever any improvement in up to a third of patients, so a clear unmet need. And as we'll hear from Jordi Diaz-Manera, in part this relates to significant changes in muscle function, including scarring and fibrosis, as can be seen on muscle MRI scan, and crucially actually in the late onset Pompe disease, including the elderly presentations, the age of presentation and the clinical picture may influence the treatment response. So how challenging are these issues? Well, unfortunately, only about 1% of the delivered enzyme given by intravenous infusions in the LOPD patients every 2 weeks at the rather lower dose of 20 milligrams per kilogram body weight actually gets through into the muscle and actually into the target organelle, the lysosome. Lots of reasons for this, of course, including problems of biodistribution, and indeed, very relevantly to infants and perhaps less so to adults, immune reactions against the enzyme. A lovely picture from Hung Do's group illustrating the complexity of how difficult it can be to give an exogenous enzyme into the circulation and yet get it into the endogenous system within the cell, going from the circulation through into the interstitium, finally into the muscle, and then into the lysosome. So lots of points at which things could go wrong. There could be problems of uptake, there could be reduced capacity and delivery, and even stabilization of the enzyme that are relevant to this difficulty. So as you would hope, innovative companies like Sanofi and like Amicus have developed new second-generation enzymes, and these have definitely been a significant evolution in treatment. One of the challenges is, vital to the uptake of the enzyme is the mannose-6-phosphate receptor. Unfortunately, it just so happens that there is a very low density of these receptors in the skeletal muscle, so that other organs, such as the liver, the kidney and spleen, can really act as a sink to take out an awful lot of that exogenously delivered enzyme, even and ever before it can actually get to the muscle cells. So one way, of course, would be to increase the number of binding sites for mannose-6-phosphate receptor, and you can see in the right-hand picture and circled with red the huge increase in the number of the binding sites of mannose-6-phosphate receptor system, biochemically engineered, on a second-generation enzyme called nexviazyme or nexviazyme or AVAL. So this was looking really encouraging, and so a large phase 3 randomized controlled trial was developed. At the time, this is one of the biggest Pompe studies in the world at the time, and it was actually an incredibly brave thing, I think, to do. So Sanofi chose to actually deliberately compare their current existing licensed treatment, myozyme lumazyme, to this new treatment in a group of treatment-naive patients, 100 patients randomized equally 1-to-1. So of course there was a primary analysis period when it was double-blinded, and then a very long extension period where all patients were offered the second generation enzyme and subsequent post-treatment follow-up. Always a challenge in clinical trials is what outcome measures are you going to choose? And it was slightly unfortunate, the choice of the primary outcome measure. So if you look at AVAL, shown in the red, there's a clear non-inferiority to their first generation enzyme, myozyme lumazyme, but it didn't quite cross statistical evidence of superiority, that is a p less than 0.05 level. By contrast, the secondary endpoint, that is the 6-minute walking time, showed a clear and statistically significant difference. So if only the other outcome measure had been chosen, or maybe even a co-primary outcome, we might well have had a different result. And it's important to put this into context and not be too negative, because quite the contrary, when you look at other measurements, for example MIP and MEP, which look at diaphragm function, you look at other measurements of the quality of walking and the quality of motor function, not just the 6-minute walking time, which is such a complicated measurement, including in fact exercise tolerance and even respiratory function, there was a clear benefit. And perhaps, and most relevantly to future trial design, was the very striking benefit seen in the patient-reported outcome measurements. And I'd emphasize this is in the randomized portion of the study where it was not known which treatment patients were on. And I think you can see, when you think of what matters to patients, shortness of breath, fatigue, particularly fatigue when combined with pain, and early morning headaches as a feature of respiratory impairment, a dramatic and statistically significant improvement, hugely more than actually was seen with the 6-minute walking test and the vital capacity, those more traditional measurements. Of course, it's important in enzyme design, and we're all aware that there can be infusion-associated reactions, and hence the need to start patients in hospital before then most patients are moved to home care. What about the safety of this new enzyme, AVAL? Well, encouragingly, it appeared to actually be rather safer than the new molecule. So that was good news. And it's certainly been approved in many countries around the world now. And obviously, thinking about the licensing in the States, I'm presenting here in the States, albeit that it's obviously an international Pompe advisory group, it's now been licensed in many countries, including in America, including in Europe, and including in Japan. So some benefits were seen, but were they maintained? Again, that important question was the durability of response. And in the extended treatment protocol, where patients were offered to be switched to the new enzyme, there was a clear and sustained improvement. So if you look on the top of that figure, you can see in red those who were on the new enzyme throughout, their response was maintained. But even more importantly, perhaps, if you look at the switch group, those who'd originally been on myozyme and lumazyme, shown in purple, when they were switched, albeit subtly, they appeared to actually improve. And that's, of course, very important to the real-world decisions that patients with their physicians have to take all the time. This was also seen when you look at not just the breathing capacity, but the walking tests. So the walking ability of patients was maintained up to 145 weeks, so this is a long time after the initial primary treatment period. The myozyme group, shown in purple, appeared to be on the verge of deteriorating, and yet, when they were switched to the second generation enzyme, they stabilized. So that's of course, we all want improvement, but in progressive disease, even if we have stabilization, that's an important goal to build on. Amicus have also been developing a new enzyme. They too sought to actually enhance an enzyme in terms of its binding abilities. They were also keen to try and ensure that the enzyme might have more efficacy at the point of the lysosome, but they were particularly concerned about the relatively hostile environment of the circulation. So we all recognise the term acid maltase deficiency because, of course, these enzymes work at an acid pH. But the pH of the bloodstream is neutral and therefore might be relatively hostile to the enzyme and cause it to break down, to denature, and therefore be less available for the uptake of the enzyme. So they chose to add in a stabilizer called Miglustat, a modified amino sugar, binding to the glucosidase site to try and protect the enzyme in the circulation and so potentially enhance its uptake. Now the PROPEL study, again a phase 3 study, a randomized study, was a mixture of patients naive, not many actually, just 27 patients naive to treatment who were going to be established on the new enzyme or myozyme, and the majority of patients who entered the study were actually ERT experienced, meaning that they'd been on myozyme for some years. A minimum of 2 years was an inclusion criteria so as to avoid the confusion of the early improvement in myozyme, potentially obscuring any benefit from the second enzyme. So patients were randomized 2-to-1 to receive either CIPA and the stabilizer or myozyme and a placebo in a trial that went on for a year, and of course, as you'd imagine, with an extended treatment protocol thereafter where all patients were offered CIPA. It's always difficult when you choose one single primary outcome measure. And as in fact with the Sanofi study, so it was with the Amicus study. So certainly a trend in blue to those patients treated with CIPA compared to those who were maintained on myozyme or initiated on myozyme for an improvement, but it did not quite reach statistical significance. But on a secondary outcome measure that was chosen, namely a very important one, of course, the vital capacity, you saw stabilization of vital capacity in those who were treated with CIPA and Miglustat, shown in blue, but a clear deterioration in those, in fact, who were treated with myozyme. And this was the overall treatment group. If you looked at those patients who were actually switched from myozyme to CIPA, the differences were even more marked, suggesting this could be a useful treatment in patients who'd been on myozyme. And it's of note, many of the patients who were switched had been on myozyme for 7 or more years. So speaking to the real-world practice decisions that we may have to make. It has to be said, though, when thinking about naive patients, the data was quite confusing. So it almost looked as though the first generation myozyme Limzyme was about as effective as this new second generation enzyme. But there are a small group of patients, and this is such a heterogeneous condition, but we certainly need to understand more about the response in the naive and not just the switch groups. And on the safety, in the main, it was just as safe as myozyme Limzyme, although, and this is often the case, there were a few quite serious infusion-associated reactions, but that's not an uncommon experience within a clinical trial, but we will need to keep an eye on this in real-world practice. And what about the validity and the durability of this response? Well, when we look at the extension period, you can show in the dotted lines there, you can see that in these groups of patients that the response was maintained. You get a hint that the myozyme group shown in purple would have deteriorated, but they appear to have stabilized with regard to their breathing capacities. And similarly, you get a hint again that the myozyme would have deteriorated, and they're stabilized by the introduction of the second generation enzyme. And in those who'd been on it throughout, that response was maintained out to 104 weeks. So I would say it's not a challenge, it's wonderful that we've actually got 3 treatment options now in terms of enzyme replacement therapies. These second generation enzymes are going to be a really important bridge to future, more definitive and potentially curative gene therapies, but that's quite a way off, and I think these enzymes are going to be with us for a long time, and they're a big evolution. We're going to need to think about how we might actually have dual treatment approaches. So, for example, substrate reduction therapy that we're going to hear about, for example, on Sunday, and gene therapies combined with ERT, and modification of ERT regimes are going to be important. But the really crucial thing is to engage with you, the patients, about how we're going to collect this real-world data, how we're going to make treatment decisions, which patients wants to switch, which treatment to switch to. And I'm sure this will come up in the roundtable later as to your feelings about which of these treatments you might prefer to use or are excited to try, and how long should that trial period be. I think it should probably be 2 years as a minimum on a new enzyme, unless early deterioration is going to be seen. And crucially, thinking back to the trial design and thinking for the future, and accepting that we're very unlikely to have a trial that compares these two new enzymes to each other in a head-to-head study. I think that's very unlikely. Importantly, patient-reported outcome measures, you, the centre of the decision, should be a crucial outcome measure. And newer agents, including MRI, are going to be useful, of course. So those are my thoughts, and thank you for the invite.